I want to tell you about something that costs less than $2, takes 20 minutes, and produces a physiological effect on joint inflammation that I have watched surprise patients who had spent hundreds of dollars on supplements and procedures that did not come close to delivering the same result. I am not going to make you wait until the end of the video to find out what it is. Magnesium sulfate, Epsom salt, dissolved in warm water, deep enough to cover your ankles for 20 minutes before bed. That is the intervention. And if you think you already know this and have dismissed it as folk medicine, I want you to stay with me for the next several minutes. Because what I am going to explain is not the vague claim that it relaxes muscles. I am going to explain the precise biochemical mechanism by which transdermal magnesium absorption reduces the inflammatory signaling inside your joints, why the majority of people over 60 are deficient in the mineral that makes this work, and why that deficiency is almost certainly not showing up on your standard blood panel even if you have been tested. I am Dr. David Miller. I have been practicing medicine for 15 years, and I built this channel on one principle. There are interventions that are cheap, accessible, evidence-supported, and almost completely ignored by the standard clinic visit because there is no revenue in recommending them. This is one of them. Subscribe to Dr. Miller right now and hit that like button. We are building a community of people who understand the difference between managing a condition and addressing its biochemical root. Every subscriber makes this channel more visible to the next person who needs it. Let me tell you about a patient I will call George. He was 67 years old. He had been living with joint pain for 8 years, primarily in his hands, his knees, and his lower back. He had a diagnosis of osteoarthritis confirmed by imaging. He had tried glucosamine supplements for 2 years with modest benefit. He had received 2 cortisone injections in his right knee, each providing temporary relief. He was taking an over-the-counter anti-inflammatory daily, something he had started doing so routinely that he no longer thought of it as a choice. He came to see me because his gastroenterologist had told him the daily anti-inflammatory was damaging his stomach lining and he needed to find an alternative. He was not expecting a significant alternative. He was expecting to be told to manage with less. When I reviewed George's labs, one finding stood out immediately. His serum magnesium was 0.82 millimoles per liter. The laboratory reference range listed anything above 0.75 as normal, so his result was filed as normal. His previous physicians had seen it and moved on. But here is what those physicians had not explained to George, and what I want to explain to you right now, because it changes how you interpret that number entirely. Serum magnesium, the magnesium measured in a standard blood test, represents less than 1% of the total magnesium in your body. The vast majority is stored inside cells and in bone tissue. Your body regulates serum magnesium with extraordinary precision because magnesium is involved in over 300 enzymatic reactions that are essential for basic cell function. When magnesium intake falls or absorption decreases, the body pulls magnesium from intracellular stores and from bone to maintain the serum level within the reference range. The serum level stays normal until the intracellular reserves are so depleted that the body can no longer compensate. By the time the serum level drops below the reference range, you have been intracellularly deficient for months or years. George's serum level at 0.82, technically normal, was almost certainly reflecting a state of significant intracellular depletion that the blood test was not designed to detect. Magnesium deficiency after 60 is extraordinarily common and driven by 3 converging factors that most people are not told about. First, dietary magnesium intake declines with age as appetite decreases and food variety narrows. Second, intestinal absorption of magnesium decreases with age as the efficiency of the magnesium transport channels in the gut wall diminishes. Third, and most importantly for people taking common medications, proton pump inhibitors, the acid suppressors used for reflux and gastritis, directly impair magnesium absorption in the gut. Diuretics, used commonly for blood pressure and heart conditions, increase urinary magnesium losses. These two medication classes together cover a significant proportion of adults over 60, and their effect on magnesium status is consistent, clinically significant, and almost never discussed with the patient receiving the prescription. Now I want to explain what magnesium deficiency actually does inside the joint, because this is the connection that turns an observation about mineral status into a direct explanation of joint pain. Magnesium is a cofactor for an enzyme called matrix metalloproteinase inhibition. These are proteins that regulate the breakdown and remodeling of the extracellular matrix, the structural scaffolding of cartilage and connective tissue. When magnesium is adequate, these enzymes are properly regulated and cartilage remodeling occurs in a controlled, balanced way. When magnesium is deficient, the regulatory control of these enzymes degrades. The breakdown of the extracellular matrix accelerates. Cartilage degrades faster than it is rebuilt. The joint becomes more susceptible to mechanical stress, and the inflammatory response to that stress becomes more pronounced and less well regulated. Magnesium also directly regulates the activity of a cellular receptor called the NMDA receptor in the pain-sensing neurons of the joint tissue. Under normal conditions, magnesium blocks this receptor and prevents excessive pain signal transmission. When magnesium levels fall, this blocking effect is reduced. The same mechanical stimulus, the same joint movement that would have produced minimal pain signals in a magnesium-replete state, produces amplified pain signals in a deficient state. This means that magnesium deficiency does not only accelerate joint degeneration, it simultaneously increases the sensitivity of the pain signaling system in the joint. George's joint pain was being driven by both mechanisms simultaneously, and neither had ever been identified as addressable. Subscribe to Dr. Miller and hit the like button. The NMDA receptor pain amplification mechanism I just described is not alternative medicine. It is published neuroscience and pharmacology. The role of magnesium in regulating pain signal transmission is well documented in the research literature. The fact that it is not discussed in a standard arthritis appointment does not mean it is fringe. It means that the appointment is not structured to identify modifiable biochemical contributors to an established diagnosis. This channel exists to fill that gap. Hit subscribe. It costs nothing, and it means the next person searching for answers to this question finds real information. Now I want to explain why the foot soak specifically, rather than simply telling you to take a magnesium supplement orally. The reason is absorption, and it is the same reason I discussed with George in detail, because he had actually tried oral magnesium supplementation before coming to see me and had stopped it because of the most common side effect. Oral magnesium, when taken in supplemental form, must pass through the digestive system and be absorbed through the gut wall. The efficiency of this process varies significantly depending on the form of magnesium, with magnesium glycinate and magnesium malate being the best absorbed forms and magnesium oxide, the most commonly sold form in pharmacies, being among the worst. But even the best absorbed oral forms have a dose ceiling imposed by the gut. When the amount of magnesium in the intestinal lumen exceeds the capacity of the transport channels to absorb it, the unabsorbed magnesium draws water into the gut by osmosis. The result is loose stools or diarrhea. This is not a dangerous side effect, but it means that many people cannot take the doses of oral magnesium that would be needed to meaningfully replenish intracellular stores without experiencing digestive disruption. Transdermal absorption, which means absorption through the skin, bypasses the gut entirely. Magnesium sulfate dissolved in warm water penetrates the outer layers of the skin through the sweat glands and hair follicles and enters the circulation directly. The warm water is not incidental to this process. Heat causes the pores and follicles to open and the skin's permeability to increase. The warmth also dilates the superficial blood vessels, increasing blood flow to the skin surface and creating a favorable gradient for the magnesium to move from the high concentration solution in the water into the lower concentration environment of the skin tissue and then the bloodstream. This process is slow relative to intravenous delivery, but it is consistent, gentle, and without the dose ceiling that limits oral supplementation. The research on transdermal magnesium absorption has been contested, and I want to be direct about that because some studies have shown limited skin penetration with brief exposure. What the evidence does support is that prolonged immersion, 20 minutes or more, in a concentrated magnesium sulfate solution produces measurable increases in serum and urinary magnesium levels. A study published in the Journal of Integrative Medicine measured serum and urinary magnesium levels before and after repeated magnesium sulfate foot soaks and found significant increases in both. The concentration that produced this effect was 2 cups of Epsom salt per gallon of water, which is the specific preparation I am going to give you. The temperature of the water matters. Too cool and the pores do not open adequately. Too hot and it becomes uncomfortable and potentially unsafe for people with peripheral neuropathy or reduced foot sensation, which is a significant consideration for people with diabetes or advanced venous insufficiency. The correct temperature is warm to comfortably hot, approximately 37 to 40 degrees Celsius, or 98 to 104 degrees Fahrenheit. If you do not have a thermometer, a simple test is that the water should feel comfortably warm when you place your hand in it. Warm enough to feel therapeutic, but not hot enough to redden the skin significantly within the first minute. Now let me give you the complete protocol, because the preparation and timing are as important as the intervention itself. The preparation is straightforward. Fill a basin or a foot tub with enough warm water to cover your ankles comfortably. Add 2 cups of pharmaceutical-grade Epsom salt, which is magnesium sulfate heptahydrate, and stir until fully dissolved. The water will feel slightly silkier than plain water when the salt has dissolved, which is the tactile confirmation that the concentration is adequate. Sit comfortably, place both feet in the solution, and remain still for a minimum of 20 minutes. During this time, you can read, watch something, listen to a podcast. The only requirement is that your feet stay in the solution for the full duration. The timing within your day matters. I recommend doing this in the 30 to 40 minutes before bed for 2 reasons. First, the parasympathetic activation produced by the warm immersion, which is the shift toward the rest and repair state of the nervous system, supports sleep onset and sleep quality when it occurs in the pre-sleep window. Second, the reduction in joint inflammation produced by the magnesium absorption is most relevant during the night, when the body performs its tissue repair and when inflammatory cytokines that have accumulated during the day's activity can be cleared more efficiently in a lower inflammation biochemical environment. After the soak, dry your feet thoroughly, particularly between the toes, and apply a magnesium oil spray or lotion to the soles of the feet and ankles if you have it available. Magnesium oil is a concentrated magnesium chloride solution that continues the transdermal delivery after the soak is complete. This is optional but meaningfully extends the absorption window. Plain unscented moisturizer applied immediately after drying, when the pores are still open from the warm water, also improves skin barrier function and reduces the dryness that can result from repeated salt exposure. The frequency I recommend for people with active joint pain is daily for the first 3 weeks, then 5 days per week as a maintenance protocol. The effects are cumulative. A single soak will produce a transient reduction in inflammatory signaling. Consistent repeated soaks progressively restore intracellular magnesium stores over weeks, and it is this gradual restoration that produces the sustained reduction in joint pain and pain sensitivity that patients like George describe. I also want to address something that is not strictly about the magnesium, but that makes this protocol more effective when combined with the soak. The warm water immersion itself, independent of the magnesium content, produces local vasodilation in the feet and lower legs. Vasodilation means the blood vessels widen. Widened vessels carry more blood to the joint structures of the ankle and foot, delivering more oxygen and nutrients to the synovial membrane and the cartilage. It also accelerates the removal of the inflammatory byproducts that have accumulated in the joint tissue during the day's loading. This is the same physiological principle behind warm compress therapy for joint inflammation, but applied in a more comprehensive and sustained way because the entire lower extremity is immersed rather than a single joint being covered by a compress. If you also add a small amount of dried ginger, approximately 1 tablespoon of ground ginger, or 2 or 3 slices of fresh ginger root, to the foot soak water, you add a third mechanism. Gingerols and shogalls, the active anti-inflammatory compounds in ginger, are absorbed transdermally through warm water immersion. These compounds inhibit the same inflammatory enzyme pathway, specifically the COX-2 pathway, that ibuprofen and naproxen target. The effect is gentler and more localized than a systemic anti-inflammatory drug, but it is real, it is documented, and it does not carry the gastrointestinal, cardiovascular, and renal risks that accompany daily use of over-the-counter anti-inflammatory medications. George's gastroenterologist had told him to stop the ibuprofen. Ginger in warm water is not ibuprofen. But in a person whose joint inflammation is at a manageable level, it can replace part of what the ibuprofen was doing without damaging the stomach lining that the ibuprofen had been attacking. How old are you? Write it in the comments right now. I want to see the age range of this audience because it shapes what I make next. If most of you are in your early 60s, I want to go deeper on restoring intracellular magnesium through combined oral and transdermal strategies, because the timeline for meaningful repletion from deficiency is longer than most people realize, and the sequencing of the two routes matters. If many of you are in your 70s, I want to address the specific joint pain patterns most common at that stage and how the magnesium mechanism interacts with the age-related changes in joint tissue biology. George came back to see me 6 weeks after our first appointment. He had done the foot soak every evening for the first 4 weeks and 5 times a week for the last 2. He had added the ginger to the solution from the second week onward. He had also switched his oral magnesium supplement from the magnesium oxide form he had been taking to magnesium glycinate at a lower dose that did not cause digestive disruption. He told me that after approximately 10 days, he had noticed that his morning joint stiffness, which had been lasting 2 to 3 hours every day for years, was resolving within 45 minutes. After 4 weeks, his knee pain during walking had reduced enough that he had stopped the daily ibuprofen without being asked to. His gastroenterologist, at his next follow-up, noted that his stomach lining showed the beginning of recovery from the years of anti-inflammatory use. George had not received a new prescription. He had not had another injection. He had spent approximately $12 on Epsom salt and $8 on magnesium glycinate capsules. He had 20 minutes less of evening television time, and he was in measurably less pain than he had been in years. Your joint pain is a biological process. It has biochemical drivers, and some of those drivers are directly addressable with interventions that the standard clinic visit will not discuss with you because there is no billing code for recommending a foot soak and there is no revenue in a bag of Epsom salt. I am not telling you this replaces investigation or that it works for every presentation of joint pain. I am telling you that for the mechanism it addresses, magnesium deficiency driving cartilage matrix dysregulation and pain signal amplification, it is among the most evidence-aligned, lowest risk, and most consistently underutilized interventions available. Fill the basin, put your feet in, give it 20 minutes and give it 3 weeks of consistency before you decide whether it is working. I am Dr. David Miller, and I have spent 15 years watching patients spend significant amounts of money on supplements and procedures for joint pain while a $2 intervention addressing a core biochemical deficit sat in the baking aisle of every grocery store. The body responds to what it needs. Give it what it needs consistently, and it will show you what it is capable of. Subscribe to Dr. Miller. Hit the like button. Share this with someone who is taking a daily anti-inflammatory and has not been told about what that medication is doing to their stomach, their kidneys, or their cardiovascular system over the long term, or about what a consistent magnesium protocol might allow them to reduce. The healthcare system profits from managing your symptoms with ongoing prescriptions. I profit from you needing fewer of them. Subscribe if that difference matters to you. This content is educational in nature and does not constitute personalized medical advice. If you have diabetes, peripheral neuropathy, reduced foot sensation, or significant cardiovascular or kidney disease, please consult your physician before starting a regular foot soak protocol. The mechanisms and interventions discussed here should be explored in partnership with a qualified healthcare provider who knows your individual medical history.